Mr. Chairman, ladies and gentlemen, again I want to thank all those who are participating at this course. And today is the dependent day, how it will go in future. I want to show a 59 years old female patient. She made a call phone to our department. She said that she was operated on for AF at Baculeva Center in 1993. She also said that doing well and because of retiring wants to check the heart. And this is the archive of Baculeva Center since 1956, more than almost 500,000 case reports inside. And this is the case of this lady. So in August 1993, with the assistance of Dr. Umarov, Fedorov, and operation nurse Maximenko, we performed the MAZE-III procedure to a woman patient, 41 years old, who suffered highly symptomatic persistent low AF. The case was done exactly as it was shown in video, which I've got, surprisingly, at the time from Jim Cox. The patient was discharged with sinus rhythm. She was seen in 1 year after surgery and never appeared since that until now. The time she called desiring to be sure that everything is going well before retiring. And here is her EKG, absolutely normal indices. So why it's so sharp, acute, the topics we're discussing? Because the frequency of atrial fibrillation is 0.5, 1% per population in any country. And Hisaguer once said that there are 20 labs very well equipped in France, and if they will be working 24 hours, 7 days a week, they can help only 2% of population needed in that. The risks are three detrimental effects: irregular heart rhythm, decreased cardiac output, and thromboembolic events. The earliest attempts of non-medical treatment of AF were left atrial isolation, artificial AV node block, and corridor procedure. In 1980, Jim Cox, with his group, described the late atrial isolation procedure, which made it possible for the heart to stay in the sinus rhythm regardless of rhythm in the left atrium. The operation abolished two of the three detrimental effects of AF, namely irregular heartbeat and decreased cardiac output, and did not exclude the risk of thromboembolic events. The first case of LA isolation we performed at this institution in 1982. Girardon described another palliative procedure for AF treatment, the corridor procedure. This procedure excluded one detrimental effect of AF, namely the irregular heartbeat. The third procedure, and historically the second, pretty often used at an earliest times, was catheter or fulguration at the beginning, ablation of AV node, and ventricular pacing. So all three detrimental effects were existing. This is left atrial isolation. We saw it on the dogs in 1979 when we were visiting for the first time Duke University Medical Center in Jim Cox himself. So left atrial isolation procedure, no clinical signs of AF, sinus rhythm, AV synchrony existing, restoration of the right atrial function, but still existing a risk of thromboembolic events. And corridor procedure, this is a strip shown by red of atrial septum from sinus node to AV node, is a corridor, so as I mentioned before. No clinical signs of AF, sinus rhythm, but both atrium are functioning outside of sinus node influence, AV synchrony existing, and still existing a risk of thromboembolic events. The three theories were explaining the mechanism of atrial activation during atrial fibrillation. A single autonomic ectopic focus in the atrium and multiple automatic foci in the atria were discounted by dividing the atria into small units, and they continued fibrillating. James Cox, with his group, accepted the intra-atrial reentry as a mechanism of atrial fibrillation and created a novel approach. The procedure excluded 3 detrimental effects of atrial fibrillation and became known as MAZE procedure. Sorry, I didn't know what will be shown by Jim, so I'm repeating some postulates from his lecture. Later, James Cox presented a MAZE-III procedure which gave high incidence of sinus rhythm and improved long-term atrial transport function. The procedure became a gold standard for the treatment of atrial fibrillation, including cases associated with the other heart diseases. And this is a very well-known scheme of intra-atrial reentry, which was accepted as a mechanism of AF and creation of specific pathway from sinus node to AV node, how it was achieved. I want to remind young physicians that there are 3 intra-atrial AV pathways. And what was done in the MAZE procedure 2 of them were cut, and the only one was doing a special way to AV node. That's why it was called MAZE, and in Russian we call it labyrinth. It's a French word, labyrinth, but it's I looked into the vocabulary, it's the same. In 1998, Hisauguer described spontaneous initiation of AF by ectopic beats originating in the pulmonary veins and thus explaining the possibility of development of catheter-based techniques for neutralization of arrhythmogenicity in pulmonary veins. In human hearts, myocardial extensions could be seen in all veins following into both atria, but the concentration of the sleeves, the originators of focal arrhythmia, were different within those veins. Sinus rhythm activation entering from venoatrial junction is over at so-called dead end. In case of pulmonary vein ectopy, venous activation precedes sinus node activation and atrial activation as well, thus giving the effect of delayed activation with all the consequences for transforming regular rhythm into irregular. But the real mechanism of atrial fibrillation until now is not known. The main idea for the transcatheter treatment was to reproduce the original MAZE-III procedure. For the resolution of a problem, many power sources were used. The stage endocardium-based catheter ablation very soon followed epicardium-based catheter ablation. Later on, the combination of endo and epicardium modality appeared also. For safety hazards from the LA appendage, different modification of it were proposed. Here is the modified from the article ATS Medical in 2009. This was also shown by Professor Cox. Concomitant MAZE-III procedure gave 97% success, standard MAZE-III procedure 92%, biatrial surgery with new energy source 90%, left-sided surgical procedure 60%, overall catheter ablation 60%, first-time catheter ablation 28% within 1 year. So Brooks and all summarized, they made a fantastic job, summarized the data from literature to impact ablation techniques on the outcomes of long-standing persistent AF ablation. So pulmonary vein isolation alone were done in 4 studies and gave not more than 22% of success. Pulmonary venous antrum ablation with PVI isolation, 4 studies, gave up to 40% or without confirmed is isolation, 2 studies, up to 56%. Linear ablation in addition to PVI gave a very wide Results 11.74%, and the other one gave 38.57% of success. The conclusion was that the variation of success between techniques does not give an answer for optimal approach, and the outcome might be in the treatment with composite of extensive index catheter ablation, repeat procedures, and or pharmaceuticals. The success of catheter ablation with paroxysmal atrial fibrillation was well established. This is a different figure by Tarasawa, who screened 2,169 abstracts and evaluated 300 full text articles. There were 32 randomized controlled trials, 9 non-randomized comparative studies, and 67 cohort studies. The conclusions was that radiofrequency ablation was effective in restoring and maintaining sinus rhythm in patients with paroxysmal atrial fibrillation in whom medical therapy had failed. Notably, the data were obtained mostly from relatively young patients with non-intact cardiac function. And this is a slide given by one of co-workers of Baculeva Center, who made an analysis of freedom of atrial fibrillation after different MAZE modifications in patients with concomitant heart disease during the first year follow-up. And you see that this all the results within 12 months are very, very low. So when we compare surgical MAZE-III and international treatment of atrial fibrillation, we see plus and minus for surgery excellent results, including interactive cases. But on the other hand, it's a complex procedure, and what to do? Simplify wide used by cardiovascular surgeons, make it routine to cover the demand of all patients needed in treatment. And if we look at interventional treatment, the plus is non-thoracotomy, no extracorporeal circulation, acceptable results for paroxysmal AF in non-intact cardiac function in relatively young patients. Minus are mediocre results within short follow-up for long-standing AF, complex modality for long-standing AF, long procedure time under X-rays. There is in the literature a case 922 minutes. Impossible to cure associated mitral and tricuspid valve insufficiency, does not affect on the sizes of mitral valve, tricuspid valve, left ventricle, right ventricle, and so on. What to do? Use only for very long-standing AF in very sick patients. Not like possible to simplify now, change for alternative types of visualization. Over the last, these are words of Professor Damiano and co-workers. Over the last 5 to 10 years, various groups have tried to develop less invasive approach using a number of different energy sources to create lines of ablation to replace surgical incision. This has led to a plethora of new operations for these arrhythmias. There is a significant confusion in the literature at the present time as to what is the best lesion pattern and what is the best energy source. It is our feeling that a great deal of this confusion is due to our lack of understanding of the mechanisms of atrial fibrillation and the effect of ablation technology on atrial hemodynamics and electrophysiology. This means only that there is no a single approach which satisfies both a physician and the patient. Even between physicians, the debates are very sharp. Some impact into the decision-making brings medical industry as well. Definitely a long time is needed to have professionally accepted indications for the treatment of varying groups of patients with atrial fibrillation. So repeating what Professor Damian and the co-workers said, Jim Cox said that atrial fibrillation has more than we say that atrial fibrillation has more than 3 detrimental effects. This is irregular heart rate, decreased cardiac output, and thrombotic events, and also atrioventricular valves, significant enlargement, should be considered especially as the 4th detrimental effect. One more argument in favor for surgery is that the 4th detrimental effect of atrial fibrillation, namely arrhythmia-induced cardiomyopathy, was never mentioned as a mandatory attribute of radical treatment, and only surgery is giving a chance to establish normal size of atrioventricular valves, which might normalize intracardiac hemodynamics and probably the sizes of atria. If you look what Pai and co-workers wrote, the effect of atrial fibrillation on the dynamics of mitral annular area determined that patients in atrial fibrillation had larger MV annuli in size. AF blunts or eliminates the phasic changes in mitral annular size during the cardiac cycle with loss of its presystolic sphincter action and so on. At our institution, the program, so we also saw this, at our institution, the program of surgical treatment of atrial fibrillation includes multiple channel epicardial and simultaneous endocardial mapping, though surgery is modified MAZE-III procedure in all cases. And we try to save the idea which was brought by MAZE-III procedure. That's why we named today our lecture like a la Cox-MAZE-III procedure. Surgery is recommended for patients with atrial fibrillation and moderate mitral valve and tricuspid insufficiency. The procedure is performed under extracorporeal circulation at a moderate hypothermia and custodial cardioplegia. And this is one patient with a moderate mitral insufficiency secondary to atrial fibrillation with slightly dilated mitral valve fibrous ring, only 35 millimeters, and we see pretty well seen mitral insufficiency, same like a tricuspid insufficiency. But we see very often in those patients the mitral valve size when it exceeds 40 millimeters. 210 cases were done from May 2009 until June 2013, and here you can see the distribution of age and duration, paroxysmal almost 42%, persistent and permanent were 58%, and the mean left atrial volume was 142 with a very big plus minus. Ejection fraction was good, and so we've done isolated procedure in 17% cases. It was at the very beginning. Mitral valve and tricuspid valve repair 41%. Mitral valve replacement to patients were with the rheumatic heart disease and tricuspid repair 31%, CABG 4%, and congenital mitral valve and tricuspid valve repair 7%. And this is what you see at the left side is epicardial mapping, and you can very easily distinguish the map on the left side, the upper one, which is a paroxysmal, and then long-standing paroxysmal and permanent. But what we did, we also put Boston Scientific electrode through the right upper pulmonary vein inside the left atrium and did simultaneous registration. And that's what you see from the right side, on the right side. So when extracorporeal circulation is started during 7 minutes of cardioplegia, instead of CART, radiofrequency ablation or cryoprobe lines in the right atrium, similar to MAZE-III procedures, are performed, and right atrial appendage is isolated. The interarterial septum is opened widely. The sizes of annuli of mitral valve and tricuspid valves are measured. Cryolines are made isolating left atrial appendage, and I will show it on the next figures. The cryoprobe temperature is 55-60 degrees for 1 minute, and finally the LAA is ligated. Here, 1, 2, 3 are intranodal pathways. 4, 5, 6 cryoprobe lines in the right atrium, and dashed dot lines opening the left atrium. I don't know, was it seen? I guess it's seen. Now both atriums are opened, and I guess everyone understands what this means. So pulmonary artery, right atrium appendage, superior vena cava, sinus node, aura, AV node, tricuspid valve, coronary sinus, right atrium, and inferior vena cava. And here is the left atrium as we see it in the during surgery, and points 8, 9, 10, and 11 are isolation lines in the left atrium. So what's first done is the left atrial appendage is isolated, and second line normally we do from the right side until it becomes more warmer. Then we do the second line, isolating left atrial, left pulmonary veins, and then connecting these two isolation lines, and that's all. And then we make a mitral valve annuloplasty, which is done in this way, but used bush at all cases. Normally with people with it depends, the size of bush depends on the weight of the patient. Normally we use number 28, but for patients close to 100 kilos and more, we use bush number 30. And we check the competency of mitral valve, which is very well seen here. Same is done with the tricuspid valve, and you can see here the lines, which was added, the one which was added for the MAZE-III procedure, and then again looking at the competency and tricuspid valve. We analyzed the results of 210 cases. 79% patients underwent surgery, including AF treatment and mitral and tricuspid valve annuloplasty. Cryoprobe required time was 16 plus minus 7 minutes. 10.5 patients were implanted dual chambers pacemakers due to junction rhythm and symptomatic bradycardia. I would like to mention that last November I asked James Cox what's the reason of this slow rhythm in 10% of patients, and he said that he knows about that, and mostly patients might stay without pacemakers, but in this country, the so long territories, we are afraid, and that's why we prefer to send the patient with the pacemaker, neither let him go with the slow rhythm. Success rate within 1 year after surgery for the whole group of patients was 90%. Separately for paroxysmal AF, it was 90.9%, and for persistent permanent AF, it was 88.5%. I'm sure that the results will change within some time, because I guess that we recognize some new details which should be considered for the future. So this is what I said, what I mentioned. So we had no complications due to cryoprobe or radiofrequency ablation. Those 5 patients were with concomitant, those who died were with concomitant pathology, no late deaths, post-op stroke resolved spontaneously in 4 patients, no late strokes, and so the results, as I mentioned, for overall group, it was 90%. What in conclusion? I'm sure that it's impossible to train enough physicians in electrophysiology performing these very, very complex procedures, even when they when they bring those results which was mentioned by me and by Professor Cox. The procedure, this one, can be easily performed by surgeons freely owning the extracorporeal circulation. It's very easy to use in redo surgery, very easily. The procedure eliminates the 4th detrimental factor of AF, namely normalizing the anatomy and function of atrioventricular valves, as well as the 3 others above mentioned: thromboembolic events, irregular heartbeats, and low cardiac output. Thank you.
Thank you, Leo. Very impressive results, and with your success rate. I didn't notice any mention of the left atrial size as a limiting factor.
It's in the figure there. Yeah, shall I return back?
Yeah. Do you consider those with more than 6 centimeters diameter to be a limiting factor because of the incidence of fibrosis in the atria?
You know what? It's a long story at our institution. We were cutting and suturing, decreasing the size. I mean, not in this series, but what we've had, I guess the biggest size we had was 5 centimeters. Mm-hmm. So, but the impression is that when you normalize the size of mitral valve and make it competent, and you exclude, by the way, this left atrial appendage, you decrease the volume of the left atrium. So I think that we can do that. We did not see a big difference due to size.
Any further question or comments? Some people are trying to reduce the size of the left atrium and right atrium. What's your opinion about that?
Yeah, that's what I said. I've done probably maybe 50 cases, something like this. It was time when I liked it to do, you know. Well, we didn't, by the way, in Perm City they do that regularly. Well, and there was a dissertation at this institution from Perm City when they were a filial of Baculeva. We didn't see much change due to that.